Okay, so we'll talk about liver and pancreas alterations. So just going back to your anatomy a little bit, the liver itself is a very large organ and it has a very high metabolic need. It is located in the right upper quadrant and it has two lobes. The gallbladder, or I'm sorry, the liver, because of its very high metabolic demand, is actually fed by two main parts of the venous arterial and venous circulation. You have a hepatic artery off the aorta that actually provides oxygenated blood to the liver, and then you also have it's also fed by a portal vein, which is actually off of the superior and inferior vena cava. This actually supplies deoxygenated blood and other nutrients for the liver. The liver itself is primarily made of hepatocytes. These are the functional cells of the liver. And these cells can actually regenerate, so that's why if you lose part of your liver, it actually will over time grow back, because these functional cells do have the ability to actually regenerate. The liver itself, as you know, is responsible for aiding in digestion. It does this by secreting bile actually into the duodenum. So this bile is a very alkaline fluid. It contains bile salt, it contains bilirubin, and it actually contains cholesterol. The bile salt is required to break down and actually absorb fats in the intestine. The gallbladder is a small little organ that sits anterior to the liver, so it's just in front of the liver, and it's actually responsible for storing and concentrating bile between meals. So bile will flow from the liver through this hepatic duct into the cystic duct and then into the gallbladder for storage. As it flows from the liver to the gallbladder, it actually flows past something called the sphincter of Oddi. That sphincter of Oddi controls flow into the duodenum. So when we eat, approximately 30 minutes after, the sphincter of Oddi will actually relax, and that will allow bile into the duodenum. The gallbladder contraction, which actually helps also push bile down, is actually controlled by the vagus nerve. So the other piece that's sort of part of this whole system is the pancreas. The pancreas is sort of a long organ. It has a head and a tail. The head is actually tucked behind the duodenum, and it's very deep in the abdomen. So the pancreas actually lies very deep in the abdomen, behind the stomach, actually. The pancreas has two functions. It has an endocrine function and an exocrine function. So the endocrine function is responsible for secreting hormones, such as insulin, glucagon, somatostatin, and another enzyme called pancreatic polypeptide. The exocrine function of the pancreas secretes enzymes that, or produces enzymes that actually secrete alkaline fluid that helps aid in digestion as well. So this fluid leaves the pancreas through the pancreatic duct, and it flows into the common bile duct, where it will meet the rest of the bile, and it will go into the duodenum as well. The enzymes that are secreted by the exocrine pancreas will actually help digest proteins, carbs, and fats. So it will release protease. Protease is responsible for digesting protein, and the main one is trypsin. It will release amylase, which is responsible for digesting carbohydrates, and it will release lipase, which is responsible for digesting fat. Okay. Now these enzymes are actually released in sort of an unconjugated form because they are very, very alkaline, and they will cause digestion of the pancreas if not careful. So they actually aren't activated until they're in the duodenum itself. So there are some disorders of the gallbladder. The two main ones that you see are stones and infection or inflammation. So cholelithiasis is actually stones, and cholecystitis is more of inflammation. So obstruction and inflammation are really the most common disorders of the gallbladder. Gallstones themselves, or cholelithiasis, are made of either cholesterol or conjugated bilirubin. They usually remain in the gallbladder, as you see here in this picture. And so at some point, though, they are usually ejected out, and what happens is they actually begin to occlude the common bile duct. And what happens when the common bile duct gets occluded is that that obstructs the flow of bile. And as the bile then backs up into the gallbladder, it causes irritation and inflammation of the gallbladder. So cholelithiasis can actually lead to an acute cholecystitis if it does actually obstruct the common bile duct. Usually cholelithiasis is fairly asymptomatic, but it can cause a lot of pain as the gallbladder contracts trying to move these stones around. That's actually can become painful. So abdominal pain and jaundice are frequently cardinal signs of cholelithiasis or stones. The patient will get jaundice because, again, the common bile duct is blocked, and therefore bilirubin cannot, bilirubin can't be released. So it backs up into the bloodstream and it causes jaundice. The pain usually from cholelithiasis usually starts 30 minutes to an hour after eating a fatty meal. And so what happens again is stones get lodged in the common bile duct. And usually you will have right upper quadrant pain, and that pain will radiate to the back and the right shoulder. And if the patient is jaundiced along with cholelithiasis, that's usually indicative that there is a stone in the common bile duct. Cholecystitis, almost always caused by obstruction of stone in the cystic duct, becomes distended. The gallbladder itself will become distended and inflamed, and so pressure, the problem with that, and the reason why many times the gallbladder is removed, is because pressure against the distended wall of the gallbladder actually decreases blood flow, and that actually can cause the gallbladder to become ischemic and necrotic, and once it becomes ischemic and necrotic, it can perforate. So it's usually a surgical emergency, and that is the reason why many people will go in and have their gallbladders taken out emergently. You will see, because this can be signs of systemic illness, you'll see fever and leukocytosis as well, very common in cholecystitis. Pancreatitis is inflammation of the pancreas, so itis being inflammation of the pancreas. Pancreatitis occurs usually because of obstruction of the outflow of pancreatic digestive enzymes. So what happens is if the bile duct or the pancreatic duct become obstructed, such as with a stone, because sometimes a gallbladder stone or a gallstone can travel down and obstruct the pancreatic duct, the pancreas will continue, the exocrine pancreas, again, will continue to make the pancreatic enzymes, amylase and lipase, that it's supposed to, but because they get trapped within the pancreas itself, the enzymes essentially will begin to auto-digest the pancreas. That will result in an inflammatory process. So this process causes damage to the vasculature and sort of a coagulation necrosis, and the pancreas, you'll get a lot of edema within the pancreas. So pancreatitis can be very challenging to treat. This is generally an acute process, and so you get the release of pro-inflammatory mediators such as all the cytokines and interleukins into the bloodstream, and that causes a systemic inflammatory response. And because pancreatitis can become this very systemic inflammatory response, sometimes it can cause shock in patients. So patients can actually suffer from more of a hypovolemic type shock. So if the cause is alcohol related, because many times people who drink a lot of alcohol frequently can have pancreatitis. The pancreatic acinar cells, so inside the pancreas are acinar cells that actually metabolize the alcohol, and they generate toxic metabolites that injure the cells themselves. And so once these toxic metabolites injure those cells, the cells will release the pancreatic enzymes amylase and lipase. Now, amylase and lipase are important because as a nurse, you are going to look at these lab values. We can actually measure the levels of amylase and lipase in the patient's blood, and if they're elevated, then that is a sign that they have pancreatitis, right? Because they aren't normally elevated in the bloodstream, but if they are, it is a sign that they may have pancreatitis. Abdominal pain is very classic in pancreatitis. It's usually less of a abdominal pain that the patient feels up front. It hurts all over, but it also radiates to the back because the location of the pancreas is behind the stomach, and the nerves that get irritated in the peritoneum actually cause a significant amount of back pain. And it's a gnawing pain. It's like on the inside of your body, so it's not like you can press on the belly and it goes away, or you move around. It's just a very gnawing kind of pain, because as you think about this, pancreas is becoming auto-digested. And the patient can frequently have jaundice because there is obstruction of the bile duct, usually from a stone. Hyperglycemia is not uncommon because of the because glucagon is actually released from alpha cells, and so when the glucagon is released, it causes the liver to release glucose into the bloodstream. So the patient, you will see hyperglycemia in the patient. Patients can again experience shock because of the widespread inflammatory process. So what happens is, as the pancreatic enzymes leak out, you get a lot of systemic vasodilation and capillary leaking, just like you would in your normal inflammatory response. So the pancreatic enzymes can actually leak out of the pancreas and out of the capillaries as the pancreas is being digested. And that actually the enzymes themselves can attack the lung tissue. And so what happens is you get what is known as a pleural effusion. You actually get a buildup of fluid in the bottom of your lungs. As you think about where your pancreas is, your lungs would sit up top. So, and many times the pain that patients feel, they don't want to take a deep breath, because if they take a deep breath, it actually can make the pain worse. Think about your lungs expanding and the diaphragm pushing down on an inflamed pancreas. So many times they will actually hypoventilate a little bit. They won't take that deep breath, and that will actually lead to atelectasis. So one of the things that you're most concerned about in pancreatitis is actually the patient's respiratory status, and so you will frequently see patients become hypoxic from pancreatitis because of these factors. Hepatitis is actually inflammation of the liver. Hepatitis, there are several kinds of hepatitis, A, B, C, D, and E. They can all cause acute icteric illness. So all of these types of hepatitis can all produce icteric illness, which means there's a jaundice component to it. Icteric is the term for essentially jaundice, usually in the sclera of the eyes is where you see it the most when you say patients have icteric symptoms. But it's caused by different strains of viruses. So hepatitis A and E are the forms of hepatitis that you get from the fecal-oral route. You will get that from contaminated foods. B, C, and D are really parenteral route or sexual route, and are transmitted when we come in contact with infected blood or body fluids. Essentially, the virus gets in and destroys the hepatocytes, which are the actual liver cells, and that causes an inflammatory response. And so because it's an inflammatory response, you get phagocytosis and destruction of those cells. So all of your normal inflammatory cells will come to try and auto-digest the viruses that's causing the cell destruction, and you get more cell destruction. These cells will begin to regenerate about 48 hours after they're destroyed, but the inflammatory process itself can actually destroy and obstruct the small bile ducts, leading to backup of bile, and that is what causes jaundice. So there typically is an icteric phase that occurs. Okay, so this is sort of a spectrum disorder from patients who have very few symptoms all the way up to fulminating hepatitis, which is a rapid onset. Fulminating is usually when the onset is quick and sudden, and it can cause liver failure, coma, and even death. So there's a very broad spectrum of symptoms, but typically hepatitis, regardless of what letter it is, has three phases. So you have a prodromal phase. That begins usually 2 weeks after you're exposed, and the prodromal phase ends with the appearance of jaundice. So once you become icteric, you're no longer in the prodromal phase. So typically 2 weeks after the exposure, within those 2 weeks, you start to feel fatigue, headache, malaise, you have a low-grade fever. Remember that this is a viral systemic illness, so it gives you all the same signs that you would think of when you think of the flu. Having the flu also causes headache, and it's highly transmissible during this period as well. Okay, so this is a time when the virus is rapidly replicating, rapidly getting into cells, and so transmission rates can be high. The icteric phase begins 1 to 2 weeks after this prodromal phase, and it lasts up to 6 weeks. So this is usually marked by jaundice. Also, you will see a very dark urine because, again, if you think about the skin being yellow and jaundiced, there is an extreme amount of bile in the patient's system. So you will see changes in your urine would be very, very dark because it also is going to have bile in it. And clay-colored stools are very classic. So the stools will become very light and clay-colored. You will also have during the icteric phase, and even actually sooner than that, you may have hepatomegaly, which is just an enlargement of the liver, and palpation of the liver causes pain and breathlessness. So if you were to, palpate up on the right upper quadrant, sort of up where the liver is, the liver would be inflamed, you would push on it, and it would actually cause an extreme amount of pain for the patient. And sometimes it takes the patient's breath away because of the location, again, of the diaphragm. You'll irritate that diaphragm as you push up on that inflamed liver. And then the recovery phase will begin with resolution of the jaundice. That's usually 6 to 8 weeks after the initial exposure. So now you're in almost 2 months after the exposure. You begin to recover from the illness. The liver will still remain enlarged for a while. That can take up to 12 weeks for the liver to return to its normal function. What you will see in patients with elevated liver enzymes, we call those LFTs, or liver function tests. Those are tests that the nurse would monitor. Those are lab tests the nurse would monitor. And you're most concerned about your ALT and your AST. So your alanine transaminase and your aspartate transaminase. So your ALT and AST are usually elevated, and that's something that we would trend as we are hopefully heading towards as the infection hits its peak. The trend will go up, and then as the resolution of the initial infection occurs, you will see these ALT and AST go down. Cirrhosis is an inflammatory fibrotic liver disease. So it's actually, cirrhosis itself is actually irreversible, and it is caused by significant inflammation in the liver, and the inflammation causes the liver cells to become very fibrotic, and it's generally caused by alcohol, but can also be caused by hepatitis infections, B and C, can also be caused by right-sided heart failure as well, because what happens is you get a backup into the portal system. So into that portal vein, you will get a backup of blood, which again causes inflammation in the liver itself. Okay, so when there's an inflammatory process in the liver, structural changes will occur in the liver cells, and they become fibrotic over time. Remember that sort of there's a pattern of the inflammatory mediators, right? You get an infiltration of leukocytes to the area, you get activation of fibroblasts on the liver, and that is going to cause structural changes, right? So over time, the liver is going to essentially harden, and that's really what cirrhosis looks like in the liver, okay? So again, the liver inflammation will cause necrosis of those liver cells, and as the body's inflammatory response is trying to heal them, the liver cells will become fibrotic over time. And once they become fibrotic, that leads to something called portal hypertension in the patient, because the cells will no longer be able to work, and you get a backup of blood through the portal circulation, and that causes portal hypertension. Okay, so if the fibrosis that causes it's the fibrosis that causes obstruction of these biliary channels that's going to essentially lead to an outflow obstruction and jaundice. So you get the obstruction of blood flow through the portal venous system, and that's again what causes your portal hypertension. So this causes shunting of blood to bypass the liver, and so generally what happens is the toxic metabolites that are made from the liver cannot leave the liver, okay? The one you're most concerned about is ammonia. So as ammonia backs up, ammonia can lead to something called hepatic encephalopathy, which we'll talk about in just a few minutes. So, the liver, over time, once these cells become necrotic and fibrotic, they fail to regenerate, right? Because once they're dead, they're dead. They can't regenerate after they're dead. They can only regenerate at the time when they are still living and injured, okay? The liver will essentially atrophy over time as it becomes sort of hardened, and that leads to a progressive liver failure in patients, okay? This develops slowly over many, many years. Cirrhosis is not something that comes on suddenly. Alcoholics are at risk because the toxins cause the disease. So many alcoholics themselves are malnourished as well, and they lack the nutrients that the liver cells need to regenerate. One of the most important things that it needs is folate and thiamine. So thiamine and folate, which are B vitamins, are required for liver cells to actually be able to regenerate. But if alcohol is your primary dietary source, you are lacking. Many of these patients will lack these B vitamins. So signs and symptoms of cirrhosis are really, fatigue and weight loss and abdominal pain. And one of the things that cirrhosis leads to is something called varices, or esophageal varices. So as the blood backs up in the portal system and you have portal hypertension, that is going to back up into the superior vena cava, and it puts a lot of pressure on all of the small capillaries that feed off of that venous circulation. And one of them is sort of these little capillaries and veins in your esophagus. So as pressure gets placed on those little varices can break open and bleed. And so patients are frequently at risk for shock and anemia because of this. Again, as the portal system backs up and as you get portal hypertension worsening, you can put pressure on the spleen as well. So patients frequently will have thrombocytopenia and leukopenia. Patients with significant liver disease tend to also have bleeding tendencies because vitamin K, there's a decreased vitamin K absorption. So because of that, patients are at risk for bleeding. So it's a very complicated systemic disease where the patients really, the marking of the portal hypertension really does put a lot of pressure on all of the body systems. Jaundice itself is also called icterus, and it's sort of when you see a yellowish, almost greenish hue to the skin, and it's really caused by hyperbilirubinemia. So you're looking at plasma bilirubin levels greater than 3 milligrams per deciliter, okay? And it can result from problems with the hepatic system, or it can also result from hematologic problems as well. So one of the ways that you can get jaundice is when you have obstruction of bile flow, such as like with a bile duct obstruction from gallstones, is very common, where conjugated bilirubin from the hepatocytes can't flow into the duodenum. So what happens is normally bile will just flow into the duodenum and you will get rid of it through your GI system. But when there's when flow is obstructed, it actually accumulates in the liver, and because it accumulates in the liver, it actually backs up into the portal system. Right? Remember I said earlier that the liver is fed by the portal vein, so you will get a backup of bile into the liver, and so it starts to leak out into the portal system. And so it'll enter the bloodstream that way. With this, you see increased excretion of bilirubin in urine because it's already conjugated and it's now water soluble. So you will actually see it'll actually flow through the renal system and go out through the urine as well. So your urine would look very dark. You can also have jaundice when you have something called hemolytic anemia. So excessive hemolysis of erythrocytes, so when your red cells actually hemolyze and break open, that can cause hemolytic jaundice. And so this is actually pre-hepatic outside of the liver, where unconjugated bilirubin is formed through the metabolism of the heme component of the hemoglobin. So remember, you have hemoglobin, heme, and globins. So in the heme component, you actually have unconjugated bilirubin formed through the metabolism of that heme. Okay, so after the red cell is destroyed, this becomes overwhelming for the liver to try and take in and actually conjugate, so you end up with hyperbilirubinemia. So the red cell breaks open and the heme and the globin basically come apart, and in that heme part, unconjugated bilirubin is formed as the heme is being metabolized. Okay, so it is it's in the bloodstream, it goes through the portal circulation, it goes into the liver to try and conjugate so that it can be dumped into the GI system. But the problem is it becomes overwhelming for the liver to try and do this. So you end up with the conjugated bilirubin just seeping back into the red blood, or back into the bloodstream. So you're not going to see, you wouldn't see this in the urine because it's really unconjugated. So unconjugated bilirubin is actually not water soluble. Okay, so in obstruction, the bilirubin is conjugated and therefore it would be passed through the urine. In hemolytic anemia, or hemolysis of red cells, you are not going to see it in the urine because it's unconjugated, okay? If there's complete obstruction of the duodenum, then stools will be light clay colored as well. And if it's a partial obstruction, then stools are going to be normal in color, okay? And you have to correct the cause. And once you correct the cause, the jaundice usually resolves. So again, once you correct the cause, the body will go about getting rid of the extra bilirubin like normal, and the jaundice will clear. Ascites are a complication usually from cirrhosis, from late-stage cirrhosis or liver failure. Ascites is an accumulation of fluid in the peritoneal cavity. So essentially fluid gets trapped and third-spaced here. And once it's there, it's very hard to get rid of because it gets trapped. And what happens is when patients have liver failure, there's usually a decreased serum albumin. So there's a loss of oncotic pressure. So oncotic pressure is pressure inside the vessels where these large proteins like albumin, actual plasma proteins, will slosh around and create oncotic pressure, and that helps keep water inside the blood vessel, okay? So because there's a loss of albumin, there's a loss of oncotic pressure, and that causes water to essentially leak out into the portal system, okay? So you're actually going to see portal hypertension as well. So you get this increase in hydrostatic pressure, and that causes water to be forced out of the blood vessels and into the peritoneal cavity. So when there's a decrease in the production of albumin, usually from the liver when cirrhosis is present, okay, because the liver is known for making albumin, and again, when the hepatocytes of the liver and the Kupffer cells become fibrotic over time, they stop doing their job. So there's a loss of albumin production. So the loss of circulating blood volume actually causes the kidneys. The kidneys are very sensitive to blood volume, and because the fluid is leaking out of the blood cells of the vascular system and into the tissue, you actually see the kidneys are affected by this as well. They activate the renin-angiotensin-aldosterone system. You may remember that from anatomy and physiology. We'll talk more about that in cardiac when we talk about blood pressure. But that causes essentially an increase in sodium and water retention. This makes the problem worse, okay? So again, the kidneys, sensitive to this low blood volume, do what they're supposed to do, but that actually worsens the problem. You get an increase in abdominal distension and girth. This becomes very evident, and there's usually large volumes of fluid in the peritoneal cavity, sort of in the tissue. 10 to 20 liters and what happens is the diaphragm gets pushed upward, and that causes dyspnea in the patient. So patients have a very hard time breathing because the diaphragm now is higher, and as the patient tries to take that deep breath, there's nowhere for the diaphragm to go, so they become very short of breath. If the liver problem is treated, generally ascites will resolve, but most of the time the liver failure itself is really hard to treat, and so what happens is we can tap the peritoneum. We can actually use paracentesis. We draw the fluid off to relieve some distress, and we can usually take off a liter or two, but it's really just palliative because the liver is failing, and so the ascites will return, but we can at least take off a couple liters of fluid so the patient can breathe a little bit better. Hepatorenal syndrome is actually functional renal failure that occurs because there's an advanced liver disease. So in a hepatorenal syndrome, you actually have renal failure, but it is not primary renal failure. It's not caused by the kidneys failing themselves. It's caused by the liver failure, okay? And this can usually be seen as a complication of usually portal hypertension. So again, the patient has cirrhosis or some kind of significant liver disease, and you get a backup of the portal circulation. And so you wind up with having a problem with the kidneys as well. You can also see it with alcoholic cirrhosis, or also fulminant hepatitis, so when the hepatitis is rapidly occurring, and there's essentially you get a functional renal failure caused by hypotension more than anything. There's a reduction in arterial blood volume, and so what happens is there is a lot of vasoconstriction in the portal system to try and get increased cardiac output, but it doesn't really work, and so it activates again the renin-angiotensin system and sodium retaining systems in the kidney, and so the kidney will try and clamp down and actually reabsorb sodium and water, but again it is only temporary, and it essentially worsens the problem over time. Okay. And so you see patients frequently will have a low systolic blood pressure, and they usually are very weak and very fatigued. You're also going to see not only the renal failure issue, but you're going to see signs of liver disease or liver failure as well. And portal systemic encephalopathy, which is really hepatic encephalopathy, is a problem when you have liver failure. So you see this mostly in patients with liver failure or alcoholic cirrhosis. It's basically impaired cerebral function, and it's caused by an increase in ammonia from the liver failure. So again, ammonia is a toxin, and it alters, once it gets in the bloodstream, it goes up to the brain and it crosses the blood-brain barrier, and it alters neurotransmission, and it causes cerebral edema, and so the brain will become a little bit swollen, and this changes, so you'll see neurologic changes in patients. You see personality changes, they're very irritable, they have some memory loss. You will also see, though, in an acute hepatic encephalopathy, you'll see lethargy and sleep disturbance is very common. One of the things that if the ammonia level is not treated and hepatic encephalopathy is allowed to continue, patients will progress from confusion to stupor, coma, and then death. One of the characteristics that you have an advanced hepatic encephalopathy is something called Ascites, which is what we call liver flap, and it's caused by the ammonia, and it's a flapping tremor of the hand. Again, it's because of the altered neurotransmission that occurs from the ammonia. Right. Patients can also have seizures as well. So you have to rid the body of the excess ammonia. That is the only way to get rid of hepatic encephalopathy. We usually do this through the use of medication. There's only one medication that does this, and it's called lactulose. And basically what happens is the ammonia will be absorbed in the gut and excreted in the patient's stool. So that is the only way to lower ammonia level when you have liver failure. Also patients, generally what we'll do is we'll put these patients on a low protein diet. Okay, and so that is the end.